Yeah, now.
Okay. So we're looking at postural assessment. We've got Hannah here doing a postural assessment for us, or volunteering to be our volunteer. We always start our postural assessment off from the posterior view, so it's less intimidating for our clients. We have them facing away and we stand behind them and start off with looking at our plumb line or our orientational reference points. So we look at our bony landmarks for reference points. And some of those reference points, if we're looking at our plumb line from the posterior view, are going to be our superior angles of our scapula. So here and here, palpating with a flat finger palpation. And looking at our superior angles down to, following down the medial border to the inferior angles, looking at those. And my thumbs I have in this position, so they create that straight line. So that's that point of reference, that straight point of reference, to be able to see if one's up higher or lower than the other. Cervical region, we may not be able to see any increase curve through the cervical region, but we can certainly see if there's any build up around that C7-T1 junction, or if there's any connective tissue build up around that area. Palpating down through our spinous processes, transverse processes we can't access, and looking right down through the thoracic and the lumbar region as well. We also want to be looking, if we're looking at the head, what's happening at the height of the ears? Is one ear higher than the other? Is one ear lower? Or can we see one of the ears more than the other, which may indicate a rotation? If you just illustrate that for us. If we can see this ear or that part of the face, that may indicate that there's some rotation in the cervical region there. Or if one ear was lower than the other, that may indicate a lateral flexion, a fixed lateral flexion position. So that, looking at the ears, and then we want to look at the curvature of the neck and the contours of the shoulders. So looking at the muscles themselves and comparing bilaterally, but also looking at the negative space, because that can give us a really good clue as to what's going on in the body if we can't pick it up looking at the muscle tone. So looking at your shoulder heights, that correlates with your scapular heights. And then coming down through the thoracic region, we're going to be looking at this negative space here in between the ribs and the arm, and then looking also at the tissue distribution over the lumbar region and over the hips, because that can give us an idea about hip heights. So bony landmark palpation for our hip heights is going to be your iliac crests. So to palpate my iliac crests, I come in at the 12th rib with my thumbs in that straight line position again. And I'll just bend down from a little bit. And I have my thumbs at that 12th rib there, and I do this up and down movement, up and down, until I hit that first bony prominence, which is the iliac crests. Okay, and we can see on Hannah here that she is a little bit higher on that right side. So I'm looking at this angle here. Now the iliac crests, it's the most posterior part, which is the highest or the most superior part of our iliac crest. So you're not looking here, it's not happening on the sides, it's where my thumbs are. All that's doing is supporting, and it's this line here that I'm looking at. That's our iliac crests. Palpation through there, through the gluteals. Comparing bilaterally again, and through the lumbar region. Moving down to the sacral region for our PSIS, just having a look over here on George, our PSIS is this area here, those two bony prominences, and we'll find those if we come about a third of the way down of the sacrum. So we know where the lumbar region starts and the sacrum finishes. If you get that reference point, you come about a third of the way down, and that should be roughly where the PSI is, or the posterior superior iliac spine, are located. So here's our L5-S1 junction there, and if I just come down a little bit further, I can also use the dimples in the lumbar, or that sacral region there, to try and find that reference point of the PSIS. Hannah's aren't all that obvious, but some people do have very obvious ones. And I do a little wiggly movement to try and locate those PSISs. So you'll need to find that first reference point of coming down a third of the way from where the sacrum starts, and then just have a bit of a wiggle around. And then you'll find those PSISs. And we're just looking at those for heights as well. Coming down past the hips and past the lumbar and into the hip region, into the lower leg, we're looking at gluteal folds, the creases under the gluteal folds, muscular tone in the hamstrings, and then the creases in the back of the knee or around the popliteal area. Once again, contour and symmetry between the two legs. So calf muscles, looking at that negative space and if there's any variations in muscle tone through there. And down into the Achilles. Looking at the angle of the Achilles, so is it straight, is it coming off to one side, more so than the other, and then down into the heels. And what can we see about the position of the feet? Are they facing forward? Are they facing out? Are they facing in? And then trying to have a look as well about the medial and the lateral malleoli. So how are they positioned? Are they prominent, or are they ill-defined? And we'll get Hannah to now turn around to those windows there so we can have a look from the lateral perspective. So we'll be able to pick up some more things based on from the lateral perspective. So those reference points are going to be the ear for our plumb line, the acromion process, the greater trochanter, the head of the fibula, and the lateral malleoli. So we're looking from the top, we're looking at the orientation of the ear to the acromion process there, and is the head sitting forward or back from that plumb line? So we're looking for forward head carriage, which would be apparent in the lateral perspective. That would also be coupled with an increased curvature through the cervical region. We can also look at the position of the shoulder in the lateral perspective, if it's actually coming further forward or sitting back, and getting a general idea about the muscle tone of the pecs. Coming down more so through the legs here, we can tell whether there is any hyperextension or hypermobility in the knees, where there's no crease in the back of the knee there, and the legs come in at quite a sharp angle, and the calf muscles sit further back there. The other thing we can look at in the lumbar region is an anterior and posterior rotation, if there's any change in the position of the pelvis, which is going to have an impact on the lumbar spine. So we may see an increased lordotic curve through here. We also may see an increased kyphotic curve through the thoracic area. So to be able to determine whether there is a anterior or posterior rotation, we need to look at our bony landmarks. So our reference points for that are ASIS, or anterior superior iliac spine, and our PSIS, the posterior superior iliac spine. So to feel or to palpate that ASIS, I start at the iliac crest with a flat hand, and I'm palpating with my thenar, coming around to the front, moving on to the fingers, and that first bony prominence that I feel is my ASIS, and then to the PSIS, same orientation that we used in the posterior aspect. And I find those two reference points, and I need to get down at that level so I can see how that's sitting. And then I use my fingers as that straight line to determine whether there is an anterior or a posterior rotation. So the natural position of a female pelvis is somewhere between 0.5 centimetre to 1.5 centimetre between the ASIS and the ASIS and the PSIS. So our this is looking on Hannah like it's a fairly neutral pelvis. So the ASIS naturally sits lower than the PSIS. So that's normal. But if we were like this, then that would be indicative of an anterior rotated pelvis. Or if we were flat, or beyond the flat, or beyond that horizontal, that would be indicative of a posteriorly rotated pelvis. So Hannah, can you just demonstrate an anterior rotation for us? That's what an anterior rotation would look like. The iliac crests are coming anteriorly and tilting down, and we get the bottom sticks out, and we get that increased curve, and just relax back to normal. And now can you demonstrate a posterior rotated pelvis? So the bottom tucks under and shortens up through the back of the hamstrings, and this lordotic curve is flattened out. Okay, and just relax. Okay, now we're going to have your standing face on. Okay, so plumb line here, or our reference points, are going to be the nose, the sternum or the manubrium, umbilicus, the patellas, and our ASISs, and then our patellas. So from the front, we're looking for the same things as we're looking from the posterior aspect. We're always looking at muscle tone and comparing one side to the other. We can look at clavicle heights to see if one sits up further than the other, or if one sticks further forward than the other, which may give us a clue about the muscle tone of the pecs. Looking at the shoulders, so the glenohumeral joint specifically, if we can see these first two fingers, that is a normal position, so I'll just demonstrate that. Actually, you can demonstrate it. These two fingers, so the thumb and the finger here, is a normal position for the glenohumeral joint, and if you just relax back into normal position, we can see how we can see more of the back of the hand of Hannah's, which indicates internal rotation at the shoulder. Muscle tone, bilateral comparison, so around the biceps and the pecs. And then down through the wrist. We look at the elbow joints and the wrist joints. So we're looking at the space in that cubital fossa. If we have any increased angle here, which may indicate tightness in the biceps, which we're not seeing here. Any pronation or supination may also be indicated coming through the elbow there. Or if we have any fixed flexion or extension through the wrist, which is much less common. Down into to the lower legs and the knees, we want to look at the position of the kneecaps themselves. So are they sitting fairly neutral, or are they sitting, is one pointing in this way, or is it pointing out this way? What's this angle like? So from the ITB area down into the knee and then into the lower leg, is there any excess angle there, which would indicate knock knees, or in the other direction, which would be a bow leg? Once again, looking at muscle tone, and then down onto our ankle joint and the arches of the foot. So to be able to determine whether someone has flat feet or excessive pronation, we want to look at the arches of the foot and that medial malleoli. Often the medial malleoli on someone who has flat feet or excessive pronation is less prominent, and we have more contact of the sole of the foot on the floor. So I can determine if there is any flat feet or excessive pronation in Hannah by just putting my fingers under that arch of her foot, and you can see I can actually get quite a few fingers in there, and there's quite a big space between that. So that's very normal arches for Hannah. Someone who had a flat foot, we would see that position come down further, and there'd be a lot more contact or surface area on the floor there.